Hello, I'm Reid from Melbourne, Australia. On behalf of my co-authors, I am pleased to present a summary of the results of our research on respiratory admissions and impact of COVID-19 lockdowns for children with severe cerebral palsy. The paper is published in Developmental Medicine and Child Neurology. Children with severe cerebral palsy have more frequent and severe acute lower respiratory tract infections relative to other children. In Australia, acute respiratory illness is the most common reason for unplanned hospital admission for this group of children. Their susceptibility to severe respiratory infection is usually attributed to poor postural control, ineffective cough, kyphoscoliosis, swallowing difficulties, and gastroesophageal reflux. Chronic airway infection or inflammation by pathogenic bacteria in the context of aspiration of food or saliva may contribute to recurrent episodes of acute respiratory exacerbation and consequently to slowly progressive lung disease that can become a major burden. Because of the factors associated with their severe CP and their propensity to chronic lung disease, these children are also more likely to have critical illness associated with common respiratory viruses. The question underlying this research was whether we could provide some light on the contribution of community-acquired viral infections as precipitants for exacerbations of respiratory disease and tertiary hospital admissions for children with severe cerebral palsy. We considered the answer to this question would be likely to have important implications for clinical management. The COVID-19 epidemic provided an unusual opportunity to explore this issue. The implementation of social restriction measures to reduce transmission of COVID-19 during 2020 and 2021 affected the transmission of other viral pathogens and the reduced incidence of related respiratory diseases in the general population. If we found the same trend in children with severe cerebral palsy, it would suggest that an important part of the burden of acute respiratory illness might be from community-acquired infections. Our aim was to compare the frequency and details of hospitalizations for children with severe cerebral palsy to a single tertiary paediatric hospital before, during, and after the period of implementation of population-level interventions to reduce COVID-19 transmission, including prolonged restrictions on human movement and contact, referred to as lockdowns. To study this, we captured data for 3 two-year periods. The lockdown period was designated as the period between the 1st of April 2020 and the 31st of March 2022. The preceding and subsequent 2-year periods were designated the pre-lockdown and post-lockdown periods respectively. A cerebral palsy cohort for each period was identified from the Victorian Cerebral Palsy Register database. Children were included in this cohort if their gross motor function was classified as GMFCS levels 4 or 5, if they were aged between 3 and 16 years at the start of the study period, and if they were living in the state of Victoria for the entire 2-year period. Children who died, migrated, or turned 19 during each study period were excluded from that cohort. Each child's electronic medical record was manually searched to identify all hospitalizations for lower respiratory tract infection or exacerbations of chronic respiratory disease during each relevant period or periods. Across the entire 6 years of the study, there were 506 eligible children and 407 hospital admissions. Most children were never admitted. 6% had a single admission and 16% had multiple admissions. The highest number of admissions was 26. Sputum culture was performed in 1/3 of admissions, mostly during the time spent in the intensive care unit. A pathogen was identified from 2/3 of cultures, with the majority solely showing growth of gram-negative bacteria such as Pseudomonas aeruginosa. In contrast to sputum culture, respiratory molecular panel testing was done within the first 5 days in 82% of admissions. A virus was detected in 39%, but in nearly half of tests with positive results, rhinovirus or enterovirus was the sole finding. Rhinovirus is the most common cause of upper respiratory tract infections. Antibiotics were used in over 80% of admissions when a virus was detected. So now I'll move on to the comparison of data across the 3 study periods. After applying the eligibility criteria, each cohort was slightly smaller than the one for the previous period, reducing from 398 to 378 to 359 children. The chosen methodology meant that the cohorts were matched for age, but included different children at the lower and upper age limits, and based on whether they were living and resident in the state. Half of the 506 children, that is 250 children, met eligibility criteria for inclusion in all 3 cohorts. A comparison of the 3 cohorts showed that clinical and demographic characteristics of the children were similar across all 3 periods. An important finding of the study was that the total number of admissions for respiratory illness was markedly decreased during the lockdown period compared to the pre- and post-lockdown periods, as shown in the first bar graph. To account for differences in the composition of the 3 cohorts, the second bar graph shows the same decrease in number of admissions during the lockdown period for the 250 children who were eligible for all 3 cohorts. This was despite there being an expectation that chronic lung disease would have likely worsened over time. To account for differences in cohort sizes, the third bar graph shows admission rates per 100 children, again showing an obvious reduction during the lockdown period. Across periods, there was strong evidence of difference in the frequency of respiratory molecular panel screening and in test results. Here we can see that admission rates where screening was not performed decreased over successive periods. In other words, more screening was performed over time. Importantly, there was a substantial reduction during the lockdown period in the rate of admissions where a respiratory virus other than coronavirus was detected, from 8.6 per 100 children to 1.6 per 100 children. This decrease mirrored trends in the wider population. Post-lockdown, admissions where respiratory viral infections were diagnosed increased beyond the levels seen during the previous 2 periods to 14.2 per 100 children. On the other hand, admissions in which rhinovirus was detected increased in the lockdown period from 1.5 per 100 children pre-lockdown to 5.8 per 100 children. Post-lockdown, admissions where only coronaviruses were detected further increased to 12.2 admissions per 100 children. This observed persistence or increased frequency of rhinovirus infections during and after the period of social restriction also mirrored trends in the wider population. So in summary, our finding of a reduced frequency of hospitalizations for respiratory illness during a period of restricted social contact implemented to reduce transmission of COVID-19 highlights the important contribution of community-acquired viral infection as a trigger for exacerbations in children who already have poor pulmonary reserve. Although acute presentation with respiratory deterioration is likely multifactorial, in this study, the contribution of aspiration and bacterial infection was less clear, partly because of the difficulties involved in obtaining sputum for culture prior to initiation of treatment. Prompt initiation of antibiotic therapy in the emergency department was the usual approach. However, this study raises questions around whether additional assistance with airway clearance and greater ventilatory support may sometimes be more important priorities. The challenge is to find ways to acquire better understanding of each child's respiratory disease and specific pathophysiology in order to create opportunities for more personalised management. So we are very grateful to the people with cerebral palsy and their families who support the Victorian Cerebral Palsy Register, and to the listed organisations that provided financial and infrastructure support. Thank you.